My beloveds, we've got clinical case. Okay, let's go. 28-year-old lady presents to the emergency department with a 2-day history of mild intermittent chest discomfort. So 28-year-old lady, 28. No, nothing, to the emergency department with 2-day history of mild intermittent chest discomfort. Okay, she has no significant past medical history, but takes an oral contraceptive pill. Oh la la! So she denies any recent long-distance travel, surgery, or personal family history of blood clots. Okay, on examination, her vital signs are stable, heart rate 88, great. No beats per minute, of course. Blood pressure 115/75 mercury. Respiratory rate is 16. Great. Her oxygen saturation 99% of on room air. So her chest is clear on auscultation, and there is no swelling on tenderness in her legs. No swelling, no tenderness. Okay, so no heart failure. Yeah. Her calculated Wells score for pulmonary embolism is 1.5, placing her in the low-risk category. What is the question? What is the most appropriate next step in managing this patient? Give me options. Immediate order a computed tomography pulmonary angiogram to definitely rule out of pulmonary embolism from the beginning. From the beginning, no. Next, discharge the patient with the reassurance the pulmonary embolism is highly unlikely. No, highly unlikely, but we have to do something before. No. Order a quantitative D-dimer test. That is... what else? Admit the patient for observation and serial ECGs. No, serial ECG on in reception is always okay. But the correct is order a quantitative D-dimer test. Yes, and this is a correct. Of course, it's correct. The case, my beloveds, this case perfectly illustrates the primary role of D-dimer test in emergency settings. The dimer test is a test with high sensitivity but very, very low specificity. We can say even zero specificity. Its greatest clinical value is highly negative value. Yes, we used to talk about that, my beloveds. Why it's incorrect? Why another options are incorrect? Okay, let's start with correct options. So why I think, and it's correct, why this option C, order a quantitative test is correct. So the patient has been risk stratifying using the Wells score, and it's determined to be a low pretest probability for pulmonary embolism. In this specific scenario, a negative D-dimer test result can reliably and safely rule out a pulmonary embolism, thus avoiding the need for more invasive and expensive imaging and radiation exposure, CTPA. No. If the dimer test is positive, and it's highly likely in this case, in this scenario, the next step would then be to proceed. If it will be positive, negative is highly likely. But if the dimer is positive, the next step would then be to proceed with imaging. No? But if negative, goodbye. So another options are incorrect. So what we've got? Ordering a CTPA, radiation exposure from the beginning, as the first step in a low-risk patient is an example of over-testing, and no, it's nonsense. It exposes the patient to unnecessary radiation and intravenous contrast without first using a simpler, non-invasive test and quick test to exclude the diagnosis. What else? Discharge the patient with reassurance that everything is great. While the risk is low, very low, it's not a 0-0. Discharging the patient without formally ruling out a potentially life-threatening, my beloveds, diagnosis like pulmonary embolism No, like would be inappropriate and safe. It's not correct anyway. Just in case, do this D-dimer test. So, and next, why the patient presentation is not typical for an acute coronary syndrome. We're talking about ECG, for which admission and serial ECG would be indicated. From the beginning, in any hospitals, we do ECG, of course. But her symptoms and risk factors points toward thromboembolic cause, which must be addressed first. So that's all. Thanks for your attention. Stay blessed. Interesting question.